We're going to move on now to talk about one of these acceptance-based approaches. There are several, including mindfulness-based stress reduction, acceptance and commitment therapy known as ACT, straight mindfulness, and so on. But for this class, I'll focus on DBT, or dialectical behavior therapy, and then we'll move briefly on to ACT afterwards. DBT combines a mixture of skills from a variety of therapeutic orientations. For example, there are behavioral techniques like skills training, exposure-based procedures, and contingency management. There are cognitive techniques like cognitive restructuring and problem solving. There are more humanistic type factors used like validation, reflective listening, empathy, and a focus on the patient-therapist relationship. There's mindfulness practice, which is acceptance-based. And you'll also notice pieces from other types of therapy. For example, the Gestalt idea of looking at the whole picture is slightly like mindfulness, in which people have increased awareness. In general, DBT is a very active approach to treatment that combines change and acceptance. Two major focuses are building up skills for a client to have more flexibility in how they respond to life, and to build up a life worth living. The idea is that clients don't want to be stuck and living in a life full of distress and turmoil, but they need help learning and practicing how to get out, how to improve, and or how to accept and move on. There are four primary modes in DBT. The first is individual therapy. So this is when a therapist and a client meet one-on-one, typically once a week for 50-minute sessions, and this would go on for 6 months, 12 months, depends on the presenting problem. The second is a skills training group. So this is group therapy. The client would go into a big room with maybe 9, 10, 11 other clients. There would be a facilitator and a co-facilitator, and it takes part over a 6-month period, and then often the client is told to, or it's suggested that the client repeat that 6-month training period. So it's almost like a class. It's not a space for individual therapy. The facilitator stands at the front and teaches skills to the group of clients. The next component kind of strikes fear into the hearts of therapists, I think, but it's the telephone consultation piece of DBT. And it's where the therapist is available 24/7 to be called by the client. The therapist can have boundaries, so I remember one of my supervisors had 2 little kids at home, so he said, I'm not going to be available between 10 at night and 6 in the morning. But for the most part, the therapists were available 24/7. Now, that's interesting because it can seem really scary that you have suicidal clients who will be calling you all night long, but what was more typical is that the clients didn't call. The clients were kind of scared of calling. They didn't want to bother the therapists. Sometimes we actually had to make telephone consultation a homework assignment, saying, you know what, we need to be using these skills outside of the 1 hour that we're together every week. And to use these skills, it can be really helpful to have a coach, so give me a call. That's your assignment over the week. And that's the idea behind telephone consultation, is that the therapist and the client can do great work together for an hour, but realistically, the client needs to be implementing these skills and using these skills in everyday practical experiences outside of the therapy setting. So the telephone consultation can help them be able to use those skills. I remember one client calling once and saying, I'm freaking out, I'm having a big fight with my boyfriend right now, I need your help. And I said to her, okay, great, I'm so glad you called, I want to help you in this situation, because eventually she needs to be able to help herself. So I said, what are the skills that you can use? What have you tried? What could you use? Okay, good, use that. Call me back in a little while, let me know how it went. So that's telephone consultation. And the fourth component is the therapist consultation team. So DBT, as you can imagine, can be difficult, can be stressful. All therapy can be. The therapist might have issues coming up themselves. Therapist consultation can include talking about difficulties with clients, problem solving, or even talking about difficulties personally. Therapists might be overly stressed out, have too much of a caseload, or have other things going on in his or her life. So therapist consultation is there as a support for many different factors in the therapist's lives. 2 other modes of treatment that might be considered are medication, but of course in Canada, psychologists can't prescribe medication, and so we'd have to be working with a psychiatrist or a physician, and hospitalization. Typically, when psychologists hear about suicide, they do tend to jump towards hospitalization, but with DBT it's a little bit different. With DBT, we certainly would use hospitalization if we thought it was absolutely necessary, after conducting a really thorough assessment based on really well-trained assessment techniques and procedures, so don't try and do this yourselves. If anyone in your lives is suicidal, hospitalization might be the best answer. So in DBT, we conduct a very thorough assessment, and then we decide if hospitalization is necessary or not. The idea is that hospitalization could make things worse for a client, because then they're not able to practice their skills in their real-life setting. So if it's not absolutely necessary for imminent suicide, then we'd rather not hospitalize someone, actually. From all the clients that I worked with, I only ever hospitalized one client. There were a lot of people that I considered hospitalization for, but then realized that it wasn't necessary after doing a thorough assessment, and tried to get them to practice their skills outside of this hospital setting, in their real lives.
As an important side note, I want you to remember that if someone in your life reports being suicidal or shows signs of suicide, or if you feel that you're suicidal, seek help right away. Don't assume that just because you have a background in psychology or because you heard about or read a little bit about suicide, you can treat someone yourself. Suicide needs to be dealt with by a professional who has extensive training in the topic. Some ideas include to call a crisis line and or to call 911.
We'll look into a little bit more detail about what happens in the therapy and in the group. This is the skills training group, but these skills are also used in individual therapy. You can see that it's a 6-month rotation of different skills that are being taught. At the top, there's interpersonal effectiveness, and that'll last for about 6 weeks. And then you can see the next orange one on the right side at the bottom there, emotional regulation. That's another skill set that's taught for about a 6-week period. And bottom left there in the orange, distress tolerance. That's a third skill set that's taught over a 6-week period. And in between every single one, there's mindfulness, because it's expected that mindfulness should be integrated into all of the skills. And so these are the 4 major skills components that are taught in group therapy and then also implemented and used in individual therapy. I'd like you to take a look at these short clips. You'll see Marsha Linehan talk briefly about some of the skills that are part of each module. In DBT, there are hundreds of skills, and these clips are short ones that'll just discuss a few of the specific skills. And remember, these skills are built into DBT, in addition to the typical CBT techniques that we use. I've mentioned that DBT can be very structured, and it typically is with individual therapy, in that the therapist will start by checking in with a diary card. So the patient every week has to fill out a diary card like this, and this can be used to track what has gone on over the past week. So you can see here the diary card can be changed depending on what's going on for the client, but you can see here that the person's written down for every day different levels of how they were feeling, different levels of emotions, different levels of self-harm. If they did, they have a self-harm SH category there, yes or no, and whether or not they lied, if they experienced any joy, and if they used any of their skills. At the bottom, you can see that they have urges down there, urges to use, urge to quit therapy, urge to harm. So the therapist, looking at this record, can give them a quick observation of how the week went for the person, and it can help see patterns of what's going on over the course of life. Perhaps nothing happened on Monday, but then all of a sudden things happened that weren't going very well for the person on Wednesday. It can also help the therapist have a place to start with treatment for that session. For example, I'll talk about this in just a second, but if self-harm is on this diary card from the week and the person engaged in self-harm, then that's probably going to be the focus of the session. Versus if there was no self-harm or suicide and the person had reported being really sad for the week, maybe that would be the focus of the session. If a client doesn't fill out the diary card, when I was being a therapist myself, I would always make them fill it out. I'd say, okay, well then you can spend the first 5 minutes trying to remember back to the week and fill out your diary card. And then after the diary card, treatment begins for a session. So treatment is done according to a hierarchy. First of all, life-threatening behaviors are considered. So if there's self-harm or suicide, like I mentioned, maybe on the diary card, or you knew that something had come up, then that's going to be addressed first. Everything else is going to be put off the table. If the patient comes in and we've been planning on doing education about panic disorder, for example, but they came in and said, I cut myself this week, then we're going to make sure we target that first, and we'll hold off on the education about panic disorder. The next thing is therapy interfering behavior. So if self-harm, suicide, things like that are dealt with, or they're not present for that week, then we'll address anything that's coming up that's interfering with the ability to make progress in therapy, like showing up late for sessions, or not showing up at all, or not filling out the diary card each week. That's a therapy interfering behavior. When I say, okay, you have to fill it out now for the first 5 minutes because it's going to give us a quick picture of what's happened over the week, that's really wasting 5 minutes of their therapy session. Or maybe they're not completing their homework, or they're not using the telephone consultation as planned, things like that. The third stage in the treatment hierarchy is quality of life interfering behaviors or patterns. So this is a huge stage. This is where we could do education for panic disorder, therapy for depression, behavioral therapy for fear, things like that. And then the fourth part is kind of integrated throughout, and it's increasing behavioral skills. So let's keep working on these skills, let's implement them in our lives, let's specifically target skills, maybe not symptoms, but skills like assertiveness training or talking about stress or relationship issues. I'd like you to watch a couple of clips now. The first one is through YouTube, and the link is on the slide. In this first video, Marsha Linehan is talking with a patient, and I'll give you a little bit of the background information so that you can understand it better. This is a male coming in because he's had a pattern of difficult relationships, each one ending with the female partner leaving him. And he's suicidal, and his sister encouraged him to come in for therapy. He describes some aspects of his relationship with his most recent ex-girlfriend, and in the clip he mentions a baby, and although it's not part of this clip, just to let you know, his girlfriend had been pregnant, but she had made the choice by herself to have an abortion, so he was really upset about this. In the second clip, you can see that these people are acting, so it seems a bit contrived, and I think they've tried to squeeze a bit too much into a short period of time. However, I think it's still a fairly good example of what a session could look like. It wouldn't be this squished in and this fast-paced. But you can see that it's very structured. It's very much skills-based as well. The client seems to have been in therapy for a while, and she's familiar with the structure and the goals of therapy and a lot of the DBT techniques that can be used. She doesn't appear to be currently suicidal or self-harming, or else they would have been focusing on that in therapy. Instead, they're talking about day-to-day issues that she might have problems coping with, and they're talking about the skills that she's learning and how to use them in difficult situations. And as you can see, the client is really responsible for engaging in therapy and for taking the skills home with her and practicing them outside of the therapy session in her real life. A big part of DBT is learning how to apply skills to real-world settings and situations. At the beginning of the session, you'll see that the client is distracted. She's thinking about other things going on, and that's not going to be effective for the session. The therapist wants to get her to be more mindful, more present for the session, so they do a mindfulness practice, help her focus on the present moment, and it helps, it works. This skill is something that she'll be able to use outside of therapy as well. So if she finds that she's distracted in a situation where it's not effective to be distracted, she'll remember having practiced this in the therapy session and she'll be able to pull on it. So this will be a more effective way for her to get through that particular situation outside of therapy, and in this moment, it's also going to be a more effective way of getting through the session together. In the second part, she does a homework check-in, and you can see here how structured the session is. Hello, check-in, homework. The homework seems to have been for the client to find a self-soothing object. This is a distress tolerance skill. When someone's in a lot of distress, one of the hundreds of coping techniques in DBT is to do something soothing. So in this case, the client found a blanket that she can be soothed by. Again, this action-focused therapy technique will translate into real life. If she's feeling really distressed in real life, she'll be more likely to self-soothe, since she had the experience of actually finding an object, doing it as a homework assignment, taking it to therapy with her, and then talking with her therapist about it. That'll make more of a difference than if the therapist had just told her, when you're really distressed, you should find a way to soothe yourself. In the third part, they get into some new material. The therapist asks her, what can you do to help yourself in common day-to-day problems that you're dealing with? And she's already had the practice in the session of doing a couple of things. As you can see, the goal is again to apply DBT skills to deal with current problems. Now I'll get into some of the outcome studies on DBT. The first study was published in 1991. It was the first study that was aimed at determining treatment efficacy, and it was conducted by Marsha Linehan. She had 44 outpatients, aged 18 to 45, who had borderline personality disorder, and she randomized them to either DBT or TAU, which is treatment as usual. So treatment as usual might consist of things like checking in with a psychiatrist or seeing a different psychologist or seeing their physician for their problems. The assessments were done at pre-treatment, at 4 months, 8 months, and then 12 months. And there were a lot of findings that were favoring DBT over treatment as usual. Patients in the DBT sessions had less self-harm behaviors, and self-harm was less severe. They had lower dropout rates compared to the treatment as usual people. They also had less hospital admissions, so less going back to the hospital. They had fewer inpatient psychiatric days, and they had lower scores on anger and higher scores on overall social functioning. In this study by Boas et al. In 2004, 50 female inpatients who had borderline personality disorder took part in either 3 months of DBT or they were on a wait list and received treatment as usual. They weren't randomized to conditions, so sometimes that'll happen in research studies where they're actually conducted in real-life clinical settings, because randomization can't work. They have these waitlist control groups, because those are the people that just happen to be on the waitlist. So it's still a control group, but it's not a true experiment. The strength was that there were no differences in the groups on a range of measures at pre-assessment. So they did pre-assessment, and then the people in the DBT group did 3 months of DBT, or the waitlist, and then they were followed up at a 4-month period. This is 1 month after DBT was finished. The DBT patients, compared to the waitlist patients, were found to have less self-harm, and they had improvements on most of the clinical outcome measures, so measures of depression, anxiety, interpersonal functioning. See that we said in the last study as well. That's probably related to the interpersonal effectiveness skills training module, social adjustment, and then global psychopathology, global psychological problems. In this study by Linehan, conducted in 2006, 101 patients with BPD aged 18 to 45 years were randomized